Welcome, everybody. My name is Ryan Law. I am the current chair of the Technology Committee for ASGE. Today, we would like to bring to you a podcast of a recently published paper that will be in IGIE in the coming months. The ASGE Technology Committee provides reviews of existing, new, or emerging endoscopic technologies that have an impact on the practice of GI endoscopy. We use evidence-based methods with a Medline literature search to identify pertinent clinical studies on the topic and manufacturer and user facility device experience database search to identify the reported adverse events of a given technology. Both are supplemented by accessing related articles featured in the PubMed and by scrutinizing pertinent references cited by the identified studies. Controlled clinical trials are emphasized, but in many cases, data from randomized controlled trials are lacking. In such case, large case series, preliminary clinical studies, and expert opinions are used. Technical data are gathered from traditional and web-based publications, proprietary publications, and informal communications with pertinent vendors. Technology status evaluation reports are drafted by one or two members of the ASGE Technology Committee and reviewed and edited by the entire committee. Today, we are here with Dr. Sam Hahn and Dr. Jorge Obando to discuss their paper, Pancreatic and Biliary Stents. This paper will be in the summer edition of IGIE, so please look for that. It will likely be in press in the coming weeks to month. Dr. Sam Hahn is a therapeutic endoscopist from Ohio State, and Dr. Jorge Obando is a therapeutic endoscopist from Duke University. From a 10,000-foot perspective, we chose to update this particular topic as it had not been updated in quite some time. This serves as an update to a more original manuscript approximately 1 decade ago. So Drs. Obando and Hahn, welcome to the podcast, and we look forward to having you describe your manuscript and why this is helpful for the ASGE readership. I think that's where I would like to start is, why do you feel that this particular review document was necessary now for the membership, for patients, for anybody who may be looking for information on this topic?
Thank
How
you
about
for having us. Yeah, I really appreciate it.
Thanks, Ryan.
Yeah,
Dr. Hahn, why don't we start with you?
Yeah, absolutely. I think the biggest kind of impetus for updating this document that was last published in 2013 was really to incorporate the expanding use of stents in the therapeutic endoscopy space, particularly with interventional EUS. As we know, US guided hepatical gastrostomy, choledochal duodenostomy, and also pancreatic gastrostomy is being more and more increasingly performed, particularly in Asia, but also in the US as well. And given that there are a lot of non-FDA approved uses of these kinds of stents, we want to go ahead and address that, saying that they are not actually FDA approved, but also explain how people are using it, which I think is most applicable to our readership. I think an important update that we also really focused on is also providing details on how to deploy these stents as well, to really give practical guidance. If you think about pancreatic biliary endoscopists or advanced endoscopists in general, really stent placement is kind of our bread and butter, and it's what we probably do most frequently. So we really want to give some practical guidance there for both plastic and metal stents. And then we also really want to expand the growing kind of evidence for all the indications for both biliary and pancreatic stents. For example, just to give one example, the use of fully covered metal stents in chronic pancreatitis biliary strictures. There's a recent major randomized trial that basically showed that you can place them for up to a year in length and in time length. So studies like that we definitely want to incorporate, and we also want to provide some growing evidence for other indications as well. And lastly, I think we really wanted to introduce the concept of biodegradable stents, because that's going to be coming down the pipeline in the next decade. They're already available in Europe, but what do biodegradable stents kind of provide? What are their technical details, and what can we expect when those actually hit the market? So I would say that's kind of like a general overview of why we wanted to update the document. Jorge, I don't know if you wanted to add anything to that.
No, absolutely. That was a great overview, Sam. Other things that might be interesting to the readership is, for instance, the evolving role of metal stents in pancreatic cancer, and how they are now recommended as a first line for drainage of biliary obstruction in pancreatic cancer, because most patients truly are undergoing neoadjuvant chemoradiation. So we need those stents to be opened reliably for long periods of time. And in addition to that, the patients are living longer lives with newer treatments, and especially the newer molecular the pancreatic cancers that can respond to different treatments as determined by molecular studies. I think it is an evolving field, and I think it's important that we mention that, and we do mention that in our paper.
I think those are all important things and important additions to this particular update. I'm glad that the paper touches on biodegradable stents. Interestingly, that the only real biodegradable stent that's taken any sort of foothold is the one that's currently available in Europe that Dr. Hahn mentioned. Although I find it interesting that despite years and years of trying biodegradable stents, we still haven't figured out a way to make a commercially available woven stent that's large caliber, akin to self-expanding metal stents. Just a little bit of prognostication while we're on that topic. Do you foresee any scenario where we get to that in the future? Because I think it's certainly ripe for whoever figures it out. We just haven't been able to, despite multiple efforts.
Good point. So as far as I remember, Ryan, years ago, 15, 20 years ago, those stents have been around, and there's always have been the promise of the next big thing. So I'm still I'm a little bit hesitant to say that they will, take over the biliary stenting world by a storm. But I think it might have to do with the economics of how we pay for things in the U.S. The more procedures we do, the more hospital systems get reimbursed, and this is goes against that a little bit. And it's a bit of a cynical way of looking at it, but it might be one of the reasons.
It's also to the economics, I think, of the fact that a biodegradable stent likely would need to be replaced, and the current or previous historical tests of biodegradable stents were quite expensive, potentially even more expensive than self-expandable metal stents. So I think it's certainly an interesting topic if somebody can figure it out to make it work and make it worthwhile, given that a lot of these patients with a pancreatic malignancy, for example, don't live tremendously long with advanced disease. Certainly with early disease, we're seeing people who are living longer. But I think it is interesting. Sam, what are your thoughts about timeline and how you would potentially use a biodegradable stent, kind of the current iteration, if it were available in the US?
Yeah, I think that's a great question. And again, as you guys are mentioning, there's very specific indications where I would think I would want to use it. In regards to kind of benign indications, if you're going to categorize benign versus malignant, I think for benign strictures, you typically think of strictures that last a long time as potentially, chronic pancreatitis related strictures. Again, though, this cost has to be offset by its relationship to fully cover metal stents. In our document, we do give the actual list price of these stents. And if you're paying $3,000 to $4,000 for a fully covered metal stent, but then you're paying the same amount for a a biodegradable stent, and one works for sure for up to a year, then you're kind of hard pressed to put a stent in that's even more expensive, that potentially won't last as long. Currently, I think the longest lasting biodegradable stents are only for 6 months. So it definitely has to kind of at least get up to that level of durability. Other biliary strictures, I'm tempted to say something like maybe like a post-transplant anastomotic stricture might be the right kind of patient, because often these patients require more than just one round of stenting with a plastic stent alone. So if you can get it to a price point where it's cheaper than a metal stent, maybe a little bit more expensive than a plastic stent, then you can kind of justify the cost of it. And then in terms of malignant strictures, Jorge's truly right about this. You either are going to go with neoadjuvant therapy, you're either going to go to Whipple fairly quickly, in which case it doesn't really matter what kind of stent you're going to put in, or you have advanced disease and your prognosis is not very long. So I don't really know in that situation. Maybe like patients who have advanced disease and you're really trying to limit the number of procedures that you want to subject them to, I would say that's kind of the target population. But for us, really, that's really just like metastatic pancreatic cancer that we're talking about for the most time. Cholangiocarcinoma is kind of its own different beast, and there's a separate ASG document about cholangiocarcinoma stenting. But those are probably like the most kind of common biliary malignant obstructions that we're seeing.
And it's interesting that the most recent version of NCCN guidelines for malignant distal biliary obstruction actually recommend placement of a metal stent, specifically a covered metal stent, which I find interesting, because I tend to be in the camp of somebody who would put in an uncovered stent before I would put in a covered stent in that situation. But we are definitely, at least at our institution, being directed by our surgeons and oncologists that they upfront want a metal stent, which is, for some of the more senior endoscopists in our group, that's a bit of a departure, as they often would start with a plastic stent. But for us, and I think at many institutions, probably similar at your own, everybody is getting 5 to 6 months of neoadjuvant chemotherapy before anybody's getting operated on. The days of an upfront Whipple, I think, are gone by and large. So, that's another important aspect of this particular document, because clinical guidelines are changing in parallel. So I think that was great for you guys to update that content. Have you seen any appreciable changes or growth in more conventional stents, either plastic or self-expandable metal stents, that is worth noting for our readership?
The only thing that I found that's super interesting, that a study, I believe, from Japan, where they treated post-sphincterotomy bleeding with a fully covered metal stent that left them typically for about 7 days, and then they removed it. And those patients had better outcomes than if they were treated with primary treatments, such as urine injection or clips or cautery. I thought that was very interesting. I've seen lots of people starting to use, covered, fully covered metal stents as primary treatment for bleeding now.
That's a great point. And Sam, I'll let you add to that, because I think you probably do want to add to that. That's a great point, though, Jorge. I have to say, in my own practice, I have a pretty low threshold for putting in a fully covered metal stent, either to treat or to prevent post-sphincterotomy bleeding, because, while they are costly, for somebody who is at high risk, whether it be anticoagulation or a long procedure or a sphincterotomy that had some amount of bleeding during the procedure, the cost of a repeat ERCP and hospitalization is substantially more than the cost of that stent. So I think goes back a little bit to the art of medicine of what we do, and thinking about when to pull that trigger as a primary prophylaxis in addition to a primary treatment. Sam, what's your kind of strategy for using fully covered metal stents for post-sphincterotomy bleeding or that sort of thing?
Yeah, absolutely. I tend to kind of go along with what you were saying, Ryan, where I have a low threshold for putting a fully covered metal stent. I do think it's probably the most effective kind of measure we have for treating these bleeds. And yeah, it's certainly an expensive kind of strategy to use, but it's durable and it works. And I think really probably more data is needed in terms of when should we be pulling these fully covered metal stents, and that's where I think the field can kind of do some more research on.
If you guys will start to kind of wrap up here, this has been an excellent kind of talk about what's available in this particular document. And I would encourage anybody in the readership to go directly to the document itself when it's available. But I'd like to ask both of you, kind of in summary, give me what you think is one single take-home point for our listeners or for the readership that this document can bring to their practice. I'll start with you, Sam.
Yeah, thank you. I really think the growing role of interventional EUS and the growing amount of stents that are being designed for interventional EUS purposes is kind of where I think a lot of our readership is going to take great interest. You know, a lot of us are already doing hepatogastrostomies and pancreatic gastrostomies, but once we get those stents that are currently available in Asia that have really like innovative designs, once we get them here, you know, one of the big news recently is Olympus buying Teu. And with that purchase, you know, we're hopeful that Olympus will be able to kind of speed the delivery of those kinds of stents to the US. But that's what I think the readership will really take interest in, and seeing how those specific indication made stents are going to be able to change our practice.
And similarly, there's I think an agreement in place, or at least tentative agreement between MITech and Boston Scientific as well in the future for distribution and selling of MITech stents, which also, similar to Taewon, have varied designs and potential limitless options for very specific indications. So I agree with you, Sam. I think that is an important evolution of what we do, and probably will continue to grow in the future. Jorge, what would you like as one kind of final take-home point to our listeners and to the readership about this document?
Sure, Ryan. Actually, you had alluded to the art of medicine, and to the readers that just limit the fact that the literature only is going to get you so far in terms of your choice of stent. You have to consider the patient. The patient comes from 4 to 6 hours away, and they might not have enough money for gas to come next time for a stent exchange. You have to be careful with, about the team that you're working with, how well is a inexperienced tech going to help you put a 4-centimeter stent versus 6-centimeter stent, which is a bit more forgiving. You know, 4-centimeter stents can potentially be mal-deployed if the tech doesn't follow all the you know, steps carefully. So it's a lot to know about how to place the right stent for the right patient in the right conditions.
Great, very, very valid point. And all of us work with that dynamic at large medical centers with patients traveling from incredible distances with actually varying backgrounds, means to pay, those sorts of things. So extraordinarily valid points, and definitely need to be part of the decision plan for patients. With that, I would like to thank you guys for taking the time out of your day to join us for this podcast. You know, this is a great way to put information about your topic and your paper out there to our readership, and promote all of the great things going on at ASGE. So, Drs. Obando and Han, thank you so much for joining us today. We're very appreciative, and we look forward to your manuscript on pancreatic and biliary stents in the coming months. Thank you so much.
Thank you. Thank you.